But in terms of SUD care and prevention, again, it's a systematic issue, and despite the advancements, the big piece is the payers, right?
Right.
Um, so that's a big one, right? Second, and I mean they're close in terms of sort of the priority of the challenges, is the lack of providers out there. And so if we look at these two, and there's a number of other issues, there's the stigma, there's the social determinants of health, which we often talk about in terms of like folks, at least a third of the country cannot or will not engage in healthcare in the way that it's currently set up. And
Right.
especially if we have substance use disorder, which co-occurs with mental health disorders as well. And certainly when we're talking about our vets, we know that PTSD, depression is much higher than it is in the general population. So that's going to impact your ability to access care as well. So lots of components here, right? But just starting from that first layer, from the payers, when you just reference the 104% of the average sort of salary in order
Mm-hmm.
to sort of access that care. The reality is because a lot of those payers out there are only going to be accepting certain insurance, right?
Yeah.
So they're not going to be often not going to be accepting veterans VA insurance. They're often not accepting Medicaid, and or Medicare. Well, just to zoom out on a few other pieces that you just mentioned before I get to that part.
Mm-hmm.
The In terms of you mentioned the rural and sort of some of the other access barriers, and just getting back to again the payer model. Again, there are increasingly more addiction or substance use disorder treatment providers out there. The problem is a lot of them, because of the way the systems are set up, Medicaid,
Mm-hmm.
VA not being able to cover it, a lot of them are for profit, right? And
Right.
so and so a lot of those expenses have to come out of pocket, right? And a lot of folks just they don't have the funding to do it, which makes a lot of sense. That's
Right.
again that gets into the social drivers of healthcare and access, which is really important. And I need to sort of like flag that those social determinants of health, which we talk about all the time, and this is what I feature in my book, Pandemics, Poverty, and Politics. Um, that really sort of underscores the sort of the issue of what we're sort of dealing with. And again, getting back to kind of the payers and the lack of providers and whatnot, there's a lot of different layers to it. But that the complexity of access gets worse the more sort of rural you become, right?
Right.
And so that's even a bigger challenge for folks. And while there's some options for like telemedicine and other opportunities, a lot of folks don't have the digital literacy in order
Yeah.
to or the understanding of the access to kind of get to it. So that's a really really important sort of piece to flag here. And when I was running a lot of COVID operations in the height of the pandemic,
Mm-hmm.
and when we saw folks that were coming in to get their COVID vaccine, which was a life saving vaccine at the time, in the very beginning, Marcus, I used to like describe it, the folks that now we were running operations like 14,000 people coming through these like Dodger Stadium every day. And I used to jokingly describe them as the triple C's, Caucasians with cars and computers, right? Because those are the folks who knew how to like access, the system. It was everyone
Right.
else that didn't, and those were the ones who were actually sort of most at risk for a number of other reasons. And those were the rural folks, those were the communities of color, and kind of
Yeah.
everything else that were not the triple C's, folks that don't understand digital literacy. So that's a really important piece there. In terms of sort of these ghost networks and sort of these kind of these sort of phony providers. I mean that's healthcare.
Yeah.
There's a lot of that in U.S. healthcare, and it's super unfortunate, particularly when we're dealing with really vulnerable or historically marginalized populations that don't know sort of where to go, and that they might find somebody and they'll take their money or whatnot, but it turns out that they're not legitimate. So it's super unfortunate. Now, having said that, there's a lot of really positive, folks out there. There's a lot of mission driven folks that are out there, but
Mm-hmm.
there's just not enough, right? And so trying to work through the workforce, and that's what I do a lot, is working with different sort of fields, so that, because again, there's not enough psychiatrists out there, there's not enough addiction medicine specialists out there, so we have to do better in terms of expanding access. So again, the community health workers, community certified peer support workers, is really essential in order to kind of like optimize that access.
What innovative therapies or policy reforms have you seen, or we should be pushing for that could actually like close this affordability gap?
Yeah, well, it's the good news. Again, I like to be an optimist. The good news, if you take away the all the political disruption that's currently taking place or whatnot, right? Like back, let's go back 6 months ago.
Mm,
There was a lot of advancement. There have been a lot of advancement in terms of opportunities to optimize access.
yeah,
Um, there's something called 1115 Medicaid waivers that certain states can basically play. It's essentially it's the state Medicaid program is essentially
mm,
asking the Department of Health and Human Services, DHHS, the feds,
yeah,
the secretary of which is, I call him the chief pseudoscience officer. So this would be a challenge right now. But outside of if we were in kind of like a normal world,
yeah,
the state Medicaid program request for to focus on some social innovation, something that's important to them, right? So in California, it was homelessness. Now it's carceral health. New Mexico is focusing on tribal health and at-risk youth. So it depends on kind of what that, and so then they get it approved, and
mm,
then they could explore some opportunities to kind of provide community impact for those folks. And so again, in California, it's called CalAIM. So it's providing stuff like enhanced care
mm,
management, community supports, and they're spinning up some potential opportunities for some other programs. So a lot of it's just like sort of wraparound service and whatnot. What it
yeah,
does though is it importantly it provides reimbursement for community health workers, peer support workers or whatnot, folks that sort of historically have been marginalized from like sort of the mainstream workforce.
mm,
And in American healthcare, if you can't bill for it, it doesn't exist, right? So now
right,
that this social innovation is allowing this alternative workforce to come more into the sort of centralized workflow, which my organization focused a lot on that. It's not there's a lot of advocacy for community health workers, but our work is really like how do community health workers more effectively work with doctors, general physicians, primary care physicians, psychiatrists, behavioral health therapists. How does it all kind of work together,
yeah,
and how do we demonstrate, sort of effectiveness? And so this 1115 waiver, and again, there's many. It's just not just California. I'm just providing a sort of concrete example. Gives us the opportunity to kind of explore these options, and then there's increasingly a lot more opportunities for us to prescribe buprenorphine. There's also now
mm,
I'm just using one example, but there's naltrexone that we're used for alcohol as well. So increasingly, there are more people that are prescribing it. There used to be something called an X waiver that was
mm,
required on a DA license, so it made it even harder. It should have been the opposite, right? It should be harder to prescribe opioids, but they made it more difficult to prescribe addiction medicine medications, which made no sense. So they repealed that. They took that away. So now it's a lot easier for them to do it. Unfortunately, a lot of providers out there, they feel sometimes a little sort of reticent, a little hesitant to prescribe. But there's enough champions out there, like the providers in my organization, that are just do it. Just do it, and the risk benefit is clear.
yeah.
Just do it, and we're getting increasingly more folks on buprenorphine and naltrexone, and it's showing like amazing results.
Yeah, man. And that's funny. I'm glad you brought that up too. About that component of that we have this real big resistance against addiction meds to fix the problem, but we're willing to overprescribe opioids, and we won't do anything to kind of reduce that or provide some type of alternative to, like, keep people from being a revolving door, so to speak. So yeah, I really appreciate that. And Dr. Evans, Tyler, our audience, veterans, families, advocates alike, they want to fight back. Yeah, and this is going to be the last question before we kind of get to a close here. By the way, what immediate steps can they take to push for better addiction care solutions? So check out Dr. Evans' book, Pandemics, Poverty, and Politics at Wellness Equity Alliance.org.